through the logistics. So I'd like to thank St. Gerson, who's my host today, who's going to do some stuff behind the scenes for me. So I share my screen. And we'll get started right now. Let's get going as people get joined in. Today, I'd like to thank everybody for joining. We're going to cover today patient-centered access and team-based care, which is standard 1 and 2 of PCMH. So let's get through some logistics first for those on the line. One, you all are on mute right now. You have a couple of options here for Q&A. I will open the session up at the very end of this. So if people want to directly ask me the question on the line, I will take that at the end. So please feel free to write down questions as we go along. I'll try to keep the pace at a way that there's lots of information I'm going to cover today. So I'll try to keep that as slow as I possibly can, but making sure I'm appreciative and honoring your time commitment to join us today. Also, if you're shy or if you got a lot of background noise, all of that good stuff, feel free to put it in the Q&A. I'll be able to see that, Sim will be able to see that, and we'll just verbally talk about those questions and answers. And then lastly, you will be able to get these slide deck. They'll be posted on our wiki, and you'll see at the very last slide, I'll keep that up, how to get to our wiki. They're also on our webcast, and for everyone who did register today, we can send them to you as well. So you can get the recording as well as the slide deck. So you'll have that to your advantage as well. And if you want to see this in full screen mode and you're not necessarily multitasking, you'll see the 2 arrows here that you can click to get it into full screen mode. So with that said, let's start rolling. So for those of you who did not meet me on the last presentation, which I'll talk about momentarily, my name is Christy. I'm the Director for Clinical Transformation for Galen Healthcare. My background in my entire career has been in healthcare. I started out as a nurse practitioner, practiced for a while. In the last 10 years, I want to say I jumped to the dark side and went into healthcare IT. And my focus has been particularly working with a variety of EMRs and helping clients over the course. So everything we're going to talk about today is all about clinical transformation. So let's look a little bit about the agenda. I'm going to go over primarily, as I mentioned, Standard 1, patient-centered access, Standard 2, team-based care, and I'll do a quick recap at a high level for all the folks joining the PCMH series that we began in March. So I'll have one slide about that and just mention that. So if you did not, and you were not aware of that, we did an introduction to patient-centered medical home in the end of March. Again, if you would like access to that at the end of this session, when you close out your WebEx, you'll be prompted for feedback, not only about the session, but you can certainly put in if you'd like that. It's also, the slide deck is available to you on our wiki as well. So that sort of goes over some of the basics. So if you're coming in and this is your first one, this is going to be a deep dive specifically on 2 standards. And we'll look at these 2 standards. I'll look at both of the elements, all the factors associated with them. I hope I give you clear-cut examples. We'll review the must-pass elements that we briefly talked about, and we'll look specifically at each factor, as I mentioned. I'll also highlight some of the scoring, the associated documentation with examples that you're expecting to see. At the very end, I'll sort of highlight for those on the phone that are currently recognized under 2011 and that are either in the process of just maintaining your PCMH status on 2011, or if you're looking and you're due for a renewal to 2014, which is the current standards and guidelines out for PCMH. I'll highlight 1 and 2 at the very end on what's new and different for those that are in 2011, for you to recognize what you need to focus on 2014. And I'll also talk about the modified rule and NCQA's stance and what happened after last fall, and I'll have a slide on that too, on how it fits into their PCMH model. So before I get into what is PCMH as a high level, I just want to, for those who aren't aware, in healthcare today, particularly in healthcare reform, it is an ever-moving target. So if you did not know and you're not looking at industry literature all day long, MACRA has just been officially out there for all of us to dig into. Some of us have heard about it, have heard names like NITs and APMs, And the reason I'm going to highlight this, if you didn't know it, this is the Medicare Access and CHIP Reauthorization Act. It came out this Wednesday. You have access to it if you go to CMS. Just type in MACRA and you can find it. And this is basically all about us leaving fee-for-service and looking at quality-based, value-based care payment reform. So MACRA will start in 2019. And the reason I'm highlighting it today is you're going to see there's two paths for clients to take, and I'm not going to focus on this at all today. The reason I'm highlighting is because if you look under MIPS, and I look right under clinical practice, excuse me, let me backpedal, clinical practice improvement activities, PCMH, patient-centered medical home, and PCSP, which is for specialty practices, patient-centered specialty practices, will fall into that area. That means if you are a PCMH recognized medical home, if you are a PCSP, which is geared to specialty practice, not primary care, you will get that 15% that's due under the MIPS program. And MIPS is really the combination of meaningful use, PQRS value modifier that rolls up. Secondarily, if you're doing APMs, these are the models, so you might hear names, and APM stands for Alternative Payment Models. CPC Plus, some of you might have heard of CPCI, which was a model that is in flux now, has been from 2012, going to end at the end of 2016. ACOs, whether it's Medicare Shared Savings Plan, or you can see the comprehensive end-stage renal or oncology, depending on your specialties. Long story short, all of these have common themes. The common themes I'm going to cover today about increased access 24/7 that I'm going to go over, and the series that we're doing on PCMH, you're going to see, regardless of the path that you get into, that some of the common themes around a patient-centered medical home or PCSP is all about both specialists in primary care delivering improved care to their patients, as well as coordinating that care. So I do that because oftentimes people wonder, why should I even do this PCMH model? What's in it for me? I covered that a little bit in the intro for those that were on our intro call, and again, for those that were, I'm glad to see many of you back today for this session and to participate in our series. I do that because there's incentives that I mentioned then that are already out there based on your state, your local region. But you can also see how that's going to tie into other programs that are coming down the pipe at a national level, such as MIPS and APMs that I'm talking about here. So with that, let's just do a high level of PCMH for those that weren't on. For those that were on the last session, you'll certainly, this is a recognized slide. Patient-centered medical home, in a nutshell, for primary care programs. So we're looking at family medicine, pediatrics, internal medicine. The key characteristics that we're looking at here are that you have a personal physician that you've selected. There's shared decision-making between the patient and the provider, so it's not just the provider saying, hey, Christy, you need to get your hemoglobin A1C down, you need to lose 10 pounds. It's really getting the patient engaged to define mutual goals that are achievable to take care of their own health. It's also looking at the whole patient, so just not prevention, but acute, preventative, chronic, and even end stage, as well as care coordination, such as referrals, labs, follow-up, engaging community resources, whether that's long-term care facilities, whether it's home health, whether it's social services, behavioral health services. And then care management is also a concept under patient-centered medical home, care plans, setting those treatment goals I mentioned. We know for a fact, there's tons of literature out there, that if you engage the patient and get them to sort of be accountable for their actions and their behaviors and their health will change, and usually in the better direction if they're involved. And then enhanced access to care, which will be some of the focus today because of one of the measures we're going to talk about. And all of these are going to lead to the overriding theme that MACRA that I just talked about and all of these quality programs are ultimately doing, right? It's about improving the health of the patients and picking that right patient population. So many of you heard me talk about this with chronic care management, which is dealing with people with two or more chronic conditions, which many people segue into PCMH. If you are a PCMH recognized organization today and are not doing the CCM billing, it's probably something to look at because you're probably already doing the work for sure. For many people, CCM is their pathway to doing PCMH. and ultimately leads to ACOs. All of this is finding the right patient population, treating them, making them better, improving their health care, while also looking at what it's costing you to do that. And that's the overriding goal of PCMH. I did mention this on the last call, but I'll say it one more time, and then for the remainder of this, just remember, here at Galen, we do recognize NCQA as the body that we follow for PCMH recognition. In the introduction, I sort of mentioned there were plenty of other recognizing bodies that can do PCMH, but we follow the NCQA standards. On the last time, here's just a high level. Again, we're going to go over patient-centered access and team-based care today. And if you have not already, please, these are free. Go and download those standards if you're considering on doing this. You'll hear me talk about going through at least these first two standards, and I'll give you some tips and tricks on a gap analysis. But in overall, there's 100 points for all of these. We'll focus on the first two standards today. You can see the levels, so obviously level 1 is the lowest, and you'll see the things that are must-pass on this slide. The ones that are in bold are must-pass. I'll talk about those specifically when we get to standard 1 and standard 2 and what that means to you. But essentially, if you're just starting out and you're currently not recognized and you want to get, you're saying, where do I even start? Start by looking at those must-pass elements. That's sort of a gauge of the minimum you have to become a patient-centered medical home. And if you met all of them, you would at least get a level 1 recognition. If you don't meet those, that's your low-hanging fruit right there, because you will not be able to pass if you don't pass the must-pass, and that'll come a little bit clearer in a minute. All right, so for those the first time joining, that's your real run debrief on patient-centered medical home. Now we're going to get into the deep dive of patient-centered access. So patient-centered access, that is the standard. Every standard will have a subset of elements. In this case, there's 3 elements, and they're usually labeled A, B, and C. And because I have my PCMH certified content expert, I'm also giving you tips and tricks as a reviewer for NCQA, that you understand what the reviewers are looking for when you submit. So patient-centered access is the standard, the elements A, B, and C. Under that, those 3 will combine to give you a total of 10 points. So in a minute, I'm going to break down each one and what they look like, and we'll go through and I'll give you an example. But we're going to talk about what's under element A, patient-centered appointment access, what's under the 24 access to clinical advice, and what's under the electronic access as well. All right, so let's go ahead and go into the first one. And lucky for us, the first one is not only a must-pass, but also a critical factor. So we'll talk about the points on this in a minute, but this is one of those. Critical factors you're going to see, because I'm going to highlight, we have another example later. A must-pass means you absolutely have to get at least 50% of the points that are allotted for this. So 1 through 6 are the factors under element 1A. So, and I'm going to sort of encourage all of you to start to get into this naming thought process. So when you're sort of discussing this, or when you do your documentation, and this will become clear in just a second, understanding that 1 is the overriding patient-centered access is the standard, patient-centered appointment access is the element we're talking about, and factor 1 is same-day appointments for routine urgent care. So thinking of the naming convention of 1A1, 1A2, if I say 1A2, then I'm referring to routine and urgent care appointments outside of business hours. Must-pass, we'll talk about that you have to have 50% of the total points that are allotted. A critical factor, in some cases, you can get points without doing the critical factor. Critical factor means this is also giving you another tip or another way to lean into. This is a critical factor to really rounding out and building your PCMH model the way that it's intended to be, and giving the care that's looking to drive the highest quality at the lowest cost. In this case, the first one we're talking about, it happens to be a must-pass and a critical factor. So same-day appointments, we'll talk about that. This is for both routine and urgent care. My tip to you means if you have a schedule today where, let's just say at 7 a.m. you block an hour for walk-ins to be available, walk-ins do not count as same-day appointments for routine urgent care. This is meaning you'll block the schedule and allowed time for specifically for routine. So if I have chronic conditions and I need to come in because I've got diabetes and hypertension, I feel like my blood sugar's not working, or even in most cases, most often people don't do well exams and hold them, but you could, and we'll get into that in detail. Routine and urgent appointments outside of business hours. We'll drive into that. So that's really having outside of the normal course of what most would consider 8 to 5. Alternative clinical encounters we'll talk about, looking at things like telemedicine, telephone calls that are scheduled. Availability of appointments. Number 4 and 5 are really do you ever look to see, what's your panel look like? If I'm a new patient, how easily can I get into your practice today, into your primary care, to see my primary care provider? How far out are you booking? And then do you ever look at no-show rates? It's really looking at, do you need to change your practice to meet your patient's needs, which is combining 4 and 5, and you're going to constantly see that transforming your practice and delivering healthcare differently than what has always been the tried and true, really geared towards that fee-for-service model, really looks at, are we opening and being available to our patients the best way we possibly can so that we improve their health, so that we make it amenable to increase their basic healthcare through the system. So we'll go through each one in detail. I'm going to start with the scoring. So for all 6 of those factors, remember there was a total of 10 points for the whole entire patient-centered access. For this, there's a total of that 10, 4.5 are dedicated to this. What you see here is that if all you get is factor 1, and remember factor 1 is having routine and same-day appointments made available to you, you would get 25%, but because this is a must-pass, that's not going to happen. Must-pass, the definition of must-pass by NCQA is that you must get 50% in order to pass that element. So in this case, you're going to see, I have to do at least 2 factors. I've got to do the first one, which is a must-pass and happens to be the critical factor. I also must do at least one of those others. So if I do the first one, then I'm either going to have my alternative clinical encounters, I'm going to have appointments outside or a process outside of normal business hours, I'm going to have to monitor my show, any one of those, and you can see the percentages that you get based on that. Okay, so what do you actually need to do? So there's 2 things, and if you haven't opened those standards and guidelines, it can be quite daunting when you read them, but there's pretty good explanations that are provided to you, and what I've basically done in this presentation is I've pulled out the must-haves that you're going to need to do. So to meet providing same-day appointments for routine and urgent care, you need to have 2 things. That's what the reviewers are going to look for. That's what you're going to have to submit when you submit your survey tool, whether you're coming up for renewal or brand new. If you don't have a policy and procedure in place, and I'm just going to say this now, when you do your policies and procedures, I will emphasize every reviewer always looks for a date and always looks for the practice name. So if you have policies and procedures on some of the things I'm going to highlight today, but you don't have date and practice name, your first thing to do is just go put a date on them. Now, the date is critical to you because the date at least has to be greater than 3 months. That policy's got to be in place before you submit your application in, or your survey tool, I should say. Let me keep doing the naming convention properly, because you get an application to say you're interested, but when you actually submit all of your data, it's called a survey tool. That date has to be on your policies and procedures at least 3 months from the time you hit that survey tool, and not over a year old. So normally what I recommend to people when you're doing these policies and procedures and once you're recognized and you've got them all, just pick a day once a year, every year, call it policy and procedure fun day, I don't care what you want to call it, that you sit down with the core group, you look at all of them and say, we change, we're good, and then you just stamp on revised date, and I'll show you examples of that. You're going to need to define what is a routine visit. I'm going to give you an example of that, and what's your time frame to get them in. Define urgent and triage urgency. Many practices, their front office staff totally know how to book appointments, know what the policies and procedures are, know what the standards are within that practice and who I can book when and what each one means. But often I find there's no formal written policy. It's just, oh, this is what we do. When you train someone, you just say, oh, here's the things, and that person just gets it. It's all in their heads. So this is really about looking at, first step, do you have it? And if you can't find it written down, that's one of your first things to do. In addition to meet this, to get your points, you also have to produce a report. 5 days, consecutive days, that's new, the consecutive piece, and I'll show you an example of that as well. So let's look at the policies and procedures. And this is a lot of words. I'm going to highlight a little bit of this. So you can see that you can see I have an effective date. You can see I have a revised date. You can see that I have the policy, the name of the practice. So for those of you that have multiple sites, each site is recognized on their own. I'm not going to get into what the multi-site application is. I sort of covered that in the intro. If this policy, for in this example, it's a SAG policy about family practice, medical group, access to care, same day. If that applies to multiple sites, you can certainly use that, right? If each one has their different rules or their different timelines and gauges, then you'd want to rename that. I'd also tell you as a tip when you're doing this policy and procedure you're writing for your staff, for your organization. If you attend some of the NCQA trainings that you can go and attend, if you're going to go in and that deep dive and pay for that training, or you're going to go PCMH and get a content expert certification, you'll often hear, don't write these for NCQA. This is about you writing and changing your practice and having policies and procedures written. This is just a way to demonstrate to NCQA that you have the PCMH model. Also, what's helpful for you when you're doing this path, you'll notice at the bottom, if you start putting, you can call the policy name, but if you start tagging PCMH and reference which element it's going for or which standard, that's always helpful. And then I'm going to give you some highlights here. Notice how I've highlighted some of the things. I'm telling you what a reviewer is looking for. I need to have 3 to 6 same-day slots available. I say that they can't be booked in advance, so that means walk-ins don't count or work-ins, whatever you want to call them. I'm highlighting for you the types of appointments, so there's urgent and routine. I define those in my policies and procedures. This is everything that's what's looked for in that triage that's in the documentation. So if I call and you can't fit me in today, and I tell you I either have an urgent appointment or maybe I do have some, you know, I've got a lot of problems and I'm calling it sort of routine, but it's not, and you don't have it, who triages it if I say I'm urgent? Who tells me, oh, yes, it really is, you need to go to the ED? So having something in here and saying that a triage nurse will touch each person or clinical staff, whoever that is appropriate in your organization. This is an example of what we're looking for when you do your policy procedure for 1A1. So what's the report look like? Again, you need 5 days. For every report, sort of there's common themes when I talked about the policies and procedures, making sure you have the date, practice name. You can consider putting in which elements referencing for every report. Make sure you put what the report's for, you put the dates or the time range. Anything you can do to point out to your reviewer certainly expedites your process, or it makes them not having to come back and forth and ask things for you. So you can see here, this is manual, right? Somebody went in, we looked at provider A, this is how many work-in or walk-in appointments they had, how many same-day appointments were available, and then what actually got filled. So your first thing is, does your current practice management system have such a report? Do you need to either internally have someone build you a custom report? Do you need to go to some outside entity and build custom reports for you out of your system if you don't have integration or the resources from the technical side of the house? Or will you have to have a resource who does this and goes into the system and just looks for this? You can certainly pull the data out, put it in Excel. You're going to put in a screenshot into that survey tool and give to them. Either one is acceptable. In many cases, some of the reports I'm going to show you today, they are manual because unless you really have a lot of integration or custom reporting skills, it may be difficult to get some of these out. As much as I'd like to do push a button, and we've certainly done some of those push a button reports for clients in the past to make it easy, but you're going to see some of these metrics, it's not going to be that simple because you've got to get data from different areas in there. So here's an example of a report that you would be submitting on the survey tool to meet 1A1. I'm saying how many got filled and what the percentage was so that you could see that. So let's go to factor 2, the documentation. So routine and urgent care appointments outside of business hours. For some of you, you might be a very small clinic and you can't expand your hours. So when we say outside of normal hours, you'll see your policy and procedure and a report, very similar to the first element that you're going to need. And that means any hours outside of 8 to 5. What does not count is if you have, normally you shut down between 12 and 1, but you open it up 2 days a week, that's not outside of normal business hours. What we're looking for is between 7 a.m. to 8 a.m. maybe, or evening hours, or early Saturday morning hours, or Sunday hours. Again, it's allowing patients to get care. So as we would all know, many patients are working full-time, right? They can't take off work or they don't have the opportunity to do that, to be able to make sure that we're making the care delivery from our practice amenable to the patient population. If you can't, because you're too small or it's just not feasible, right? You've got to pay people to switch hours, and do you really have the organization behind you to open up or have evening hours? It's okay, you can still meet this. You can contract with someone. Now, if you have an urgent care, you can contract that there's a certain amount of block times, not to show up as an urgent care sick person, but that they block off a certain time, and you have in a policy. If you need to seek it, you'll call us, we'll book the appointment for you. So you can contract with urgent cares, with other entities that might have evening hours, and that also would suffice. And then you're going to give a report, similar to the other one. How many people came into that time frame? So let's look at an example of one of the policies and procedures. Now, in this example I've given to you, in theory, because I'm giving you an example and I'm showing you that we have evening hours, Monday and through Thursday from 5 to 8 and Saturday, in theory, you don't need all of this, right? Because you don't meet that. I've sort of, just to streamline this slide a little bit, I've put both in this policy and procedure. So let's just say you were 8 to 5 strictly, you didn't have evening and weekend hours. This is the portion you'd look, right? I'm saying where to go. It's a policy and procedure. We'll talk about later the new patient packets, which is in one of these. You're saying what the conditions are that they would go, and what they will see and what they won't see, and how quickly I will get documentation from that visit. So this is some of the core items that are in the policies and procedures that are being looked for. And then again, those reports, how many appointments? At the very end, if you didn't remember all those factors a minute ago, the very end is looking at quality improvement. Do you have a large population? This is going to help you to meet that last factor 6. What you're looking for is, okay, so I have this many appointments open. How many people are coming in after 5 p.m.? That's basically what you're showing. And notice how I've highlighted here PCMH 1A2. You'll often see in something, if you're in the middle of gathering your data and putting it into the survey tool, oftentimes people will go into their policy and procedure, or they'll go into the report and they'll use Snagit. That's a great tool, or whatever, similar tool that you could use. and point to the reviewer, this is the factor, or this is the element and factor that I'm looking for, this is the one I'm needing. You're doing that sort of expedites. Now, they won't just look at that, just so you know. They'll look at the whole thing. Sometimes people might say one thing and the reviewer gives you the points because you didn't think you met it. So just so you know, you don't have to do this, but it is a nice little tip. It also helps you just to sort of dot your I's and cross your T's that you've got all the documentation and reports that you need. Because as you can see, in some of these, you have to do both. In future examples I'm going to show you, and sometimes they're just screenshots out of your system. So let's move along to the last one. And this is alternative types of clinical encounters. Again, examples of these are telephone appointments, could be telemedicine. Maybe I'm doing a video chat with a patient. Maybe I live in the area and I got a bunch of snowbirds. I still take care of them, and I say I want to check in with them. This isn't on the fly. This is proving that you've got an alternative clinical encounter. That means you've built it in your practice management system, you have it in your EMR, and it's a scheduled event. When I alluded to CCM as sort of a platform to this, for everybody that's doing chronic care management and tracking the non-face-to-face time, I usually say don't try to just hope that you get a hold of the patient. If you're segueing and going down the path of PCMH, make that telephone appointment a scheduled time. If you want me as a patient to show up, Christy, I need to talk to you. I need to check on your hypertension. I want you to do your blood pressure 3 times a week. I'm going to call you the first and third Tuesday of the month, and here's the appointment time. Does that sound good to you? It's like booking appointments. So in this factor, we're looking for the same thing, that you have scheduled telephones, scheduled telehealth time to be able to call back patients. Many patients call back lab results. Book it in advance. That could help you meet this. You know, if nurses, if you have a call center and that's what they're doing half the day, not just taking incoming, but purposely calling back, another way for you to consider doing this. This one, the report's different. You need 30 days of showing that. And you'll see I cheat a little bit because I wasn't going to do 30 days worth, but let's look at the documentation first. So first, what they're asking is you need to define what are those alternative types. Now, this is a little bit more than what you need, right? I said there's provider appointments, what those classifications are. There's nurse appointments, what falls into that. Again, many organizations don't necessarily have this documented in this way. They do it. I'm sure half of you, if you don't have that and going, oh my God, how am I ever going to do this? I bet you do it. Your staff know how to do it. No one's just ever written it down. Sometimes it's taking a stock template like this and tweaking it to fit your needs. Sometimes it's sitting down and just interviewing the staff. Tell me all the different appointment types, when do you book this, and putting it on paper. That can be your policy and procedure. Defining a telephone appointment. How soon will I call them back? How can they be booked? Also, group shared visits count for this. And I highlight this because you'll hear about it, and it's in the documentation. So I gave you some examples. An example would be if I bring all of my, maybe I've got 8, 9 diabetic type 2, and I'm going to bring them in as a group visit. It's not education. So if you're bringing them into a diabetic counselor education, that does not qualify. But if I'm the provider and I'm having a group or shared visit, where we're talking about, you know, weight loss, if I'm talking about managing and we're going around the room, it's a little bit different. Same thing about obesity and weight loss. So again, it's a normal visit with your provider, has counseling to it, not strictly education, right? It's more of, think behavioral health and counseling sessions, but looking at target populations. I'm just giving you 2 that could be examples. I'm not saying that you have to do group shared visits to meet this. It's just a type of a clinical alternative encounter that you could do. Most organizations will try to do telephone appointments because they spend time automatically calling them. And then what's the report look like? Again, notice at the top where I have alternative appointments, I've given you a full month range, right? You can see that. Now, I cheated and sort of put different dates. You need, when you submit your documentation, you have to give them the full 30 days. And really is, how many appointments did you have? How many got scheduled? How many were utilized? If you're going to do group, again, when you take stock, and at the very end, I'm going to give you an example of a gap analysis that we have here and we use when we're going out to clients. Look at some of these reports and say, how am I ever going to get this? Can I get it? Is it something I can automate? Can I pull out? Do I have staff to do that? Or will I have to do this manually? And who's going to be that person who does that? Some of you, you know, if you got recognized, and this isn't stuff you may or may not be doing all the time, and you wait until you're up for renewal, I will tell you, and I'll give you, if you have not heard, the 2017 standards, the process will be moving forward. It won't be every 3 years renewal. There are going to be some baby check-ins that's happening that will happen yearly. So it's not completely defined because that's part of the redesign for PCMH. For PCSP, it's already in place with their new standards for 2016. So just something to think about. Doing this for the first time can seem daunting, but you also need to consider once you've done it, is maintaining that. And how often would you run this report? How often would you do this report? Do you really want to wait till your renewal or for that annual in the forthcoming of the redesign? Or would you check on it every quarter, every 6 months? These are things when you're writing your policies and procedures, define who runs the report or how often reports run. It makes it easier to execute on. All right, so let's go to 4. And 4 and 5, I'll go a little bit faster. This is basically about availability appointments. Oftentimes people put into their practice manager, they put their schedule template for provider X, and you know what, that's the way it is, and it normally doesn't change unless they say, oh, you know, I want this day off starting now, and we'll switch it. But oftentimes people don't look at how often people show up, and in this case, this is about availability appointments. And what the standard is, this is really using the gold standard is looking at the third next available appointment. So that's looking at and measuring the length of the time from when a patient contacts the practice to request an appointment to the third next available appointment on their clinician's schedule, their clinician's preferred schedule. So this is the standard that NCQA uses. It's based on the Institute for Healthcare Improvement. That looking at the third next available appointment tracking is a more sensitive reflection of a true appointment availability. Because, and I'll walk through in a minute how you do this, but if I, and the definition is going to be written in the policy, I'm going to show you, but if I call today and I'm a new patient and I want to make an appointment and there's none today, there's none tomorrow, and there's none the next day, that's fine and dandy if I'm not looking at it the right way, but I could have had a whole bunch of cancellations today, which makes it look like I've got more availability than I did. And it's well known that in primary care, some of the problems is the shortage with the primary care providers and being able to get access to your provider when you want it. So looking at what you need to have in that policy and procedure or defining that appointment availability, and then monitoring the process of that. And then once again, you're going to have to give a report. The goal is to be at 0. So let's sort of look at that. And I would tell you to focus on, in this slide, is looking at the definition. I embedded it in this example, in this template of this policy and procedure. But it's really from the time that I request an appointment that I can get a new patient visit, a routine exam, or maybe a follow-up exam. And oftentimes you'll see people distinguish all 3 of those, even though many people will focus on the new patient exam. I mean, if I polled all of you and you all raised your hands, how long you were going to a new provider, you know, I often call and I'll say, oh, we're booking out 2 months, 6 months. That's not the ideal, right? It's looking at if I'm brand new and I want to give, improve the health care to the patients, and maybe they have lots of problems, I don't even know they're a new patient. It's about how quickly I can actually see them. And that's just someone going in. Again, you can see that this policy and procedure, we highlight at the bottom that there's going to be quarterly reports. Maybe I'm going to, and it says the office staff will report utilizing a dummy patient. I'm going to say patient X called today, and they're going to try to figure out when can I get a new patient for provider X, when can I get a follow-up with provider X, when can I get a routine wellness exam with provider X. And again, picking a day and just giving that for each month to the provider. So the last paragraph is a little bit probably more than you possibly need. But if you're going to develop policies and procedures, and they're going to be in your organization system to be able to see, you really want to make it intuitive for people to execute on. So here's one of those reports. You can see for January the 4th, the third next appointment was 0. That means all of them were able to have that. You know, your goal is to shoot for 0, but you can see there's certain days, maybe provider C, maybe he's jam-packed, maybe he's got a full panel of patients, or she's got a full panel of patients, and really we need to look at, do they get extended hours? Is that person maxed with their patient population and their patient panel? Same thing for monitoring no-show rates. Pretty straightforward and simple. Define what a no-show rate is and giving a report for 30 days. And again, this is really looking at, are you keeping your practice up to date to meet your patient's needs? That's what the essence of both of these are. So that you look at who's not showing up. Do you have to institute call reminders? Why aren't they showing up? If they're not showing up, what's going on with their health care? A report, pretty simple. You can see that I took the, you know, this report should look similar to you. I just embedded, instead of putting it on the very first slide, you could have one report like this that meets all of these factors in it, right? In this case, I'm saying, here's how many cancellations I had, here's the number of no-shows I had. If writer D has a lot of no-shows, you know, I'm going to go into the last factor. That's all about, well, why does that? Investigate. That's part of it. Not, instead of letting things be stagnant and not changing, looking at, do we have to change something, whether it's those hours, is there something we need to do as patients? Does that provider have the sickest patients and they end up being hospitalized and they don't show up because they don't remember? You know, what is driving that? And that leads to the last thing. Standard 6, which is coming in a future webinar series, is all about quality improvement. It's a full dedication, but you're going to see where NCQA embeds in this case, in Factor 6, we're looking for quality improvement across that. You're constantly vigilant in your practice, and you're really looking at defining and changing the way you deliver healthcare. In this case, think of Plan, Do, Check, Act. I do something, do I monitor it? Where do I regroup? Lessons learned, all sort of similar things. So what are you monitoring? How often do you monitor it? And you can do one of two things. You can either do a report to say, do a baseline is my recommendation. What's your no-show rate today? Is that something shocking to you? What's your availability rate today? And then as soon as you get your baseline, maybe you put in your policy and procedure when you're building that out if you haven't. Our goal here is to have a 5% no-show rate, or, you know, I randomly picked that number off my head, but you can also do, if you don't do a report, you can also use the quality measurement and improvement worksheet, which is all tied to Standard 6. So I'm not going to go into the process of how to do that. I will when I get to Standard 6, because that's the bulk of the major tool you'll probably use. Okay, so that was all Element A. So if you were overwhelmed, take a deep breath, relax. If you said, I've got this in the bag, then great, we're moving on to the next one. What I will tell you at the end is focus on the low-hanging fruit. I'm constantly going to say that. When I have a huge daunting task, I sort of take the things off my checklist that are easy. And this one may be easy for you. This is about access to clinical advice. And you're going to see here that number 2 is a critical factor and must be met for the practice to score higher than 25% on the element. And you'll see that in the scoring in a minute. So continuity of medical record. So how do people, when the office is closed, who gets access to the record? That's basically it. How does on-call staff have it? How do external facilities have it? And we'll go on that in a deeper dive. Clinical advice by telephone. How do patients call in off hours? What's the turnaround time on that call-in? What's the standard? If you don't have that in your policy and procedure, you're going to see me highlight that in a minute. And then are you using a portal? Do you have the ability to give by secure messaging, if you will? And so you can still meet this and not have a portal in place if you don't have one. So you're going to see that. You'll at least get some points. Also, if you've given such clinical advice, whether it was through the portal or through the telephone, What's the process of getting it into your patient record? What's the time frame to get it in? And you're going to have to show that you're getting it in. So let's look at the scoring. So here's an example where there's a critical factor, and even if you don't meet the critical factor, unlike the first one I showed you a minute ago, you still can get some points. So the first one was you had to meet that critical factor. This one you don't necessarily. You could at least get 25% of 3.5 points. And I know the point system can sometimes be difficult, right? Because 75%, if I only get 3 factors, then your reviewer is going to give you 75% of 3.5. So the math gets messy. You know, you'll see a little workbook that we've put together to help you with that, and that can certainly be a guide. But basically, you know, depending how many factors I get, it's how many points, and it's a total of 3.5. So what's the documentation? Because this is sort of similar, I'm going to sort of cover a lot of these together because they're a little bit easy. So for 1, 2, and 3, and 4, you need a policy and procedure for all of them. So again, date and practice name has to be on all of them. For number 1, you really just need to define the access to the care and the medical record. And I do have an example of that. And in fact, I have an example where I've put all of these and I've even highlighted them that I'll show you. You need to talk about the response time. If someone calls in, how do they call in and how quickly do they get responded to? That's what we're looking for when we're looking at your policy and procedure. And then define the charting requirements. So how quickly do they have to turn that around and what has to be in the chart. So here's an example of one that looks like that you can see. And I'm just going to overlay this so that I point out, again, you do not have to, you certainly don't have to highlight and do this. I'm doing this for you to be able to understand which factor I'm calling out. But you can see at the bottom some of that, you know, I'm trying to give you the best practice here, right? You don't have to do this. This helps you when you come up for renewals or and when you're looking to see if you have them. You also do not have to point them out like this. Your reviewers love it, but you don't have to do it. They're still going to look because sometimes people didn't know, you know, maybe they pointed the wrong thing, they still met it. It's a nice to have. I'm sort of doing it so that you can understand. So you can see in Factor 1, all staff and providers have access to their medical record 24/7. So that means every staff, whether if you have remote access from home, you have some manner in how to get it. Also, I'm clearly defining out if it's off hours and someone calls our on-call line or calls the beeper, that they call the answering service, someone's going to talk to them within an hour and get them back on the phone. I also define if it's during business hours, normal business hours. So for those of you who have call centers or the clinical staff, what's the turnaround time? How often, if I get a voicemail because I happen to be on multiple calls or I'm just flooded at the Monday morning, how quickly will I return, at least leave a message? Maybe I don't get the patient back, but I've tried to get back to that patient. And then defining the portal. If you have a portal, how quickly when you respond to a patient in the portal, what's that turnaround time? And then lastly, what's the minimum of the documentation? How long before you expect it to be in the healthcare record? So in this example, we're saying in 24 hours, your note documentation has to be in the medical record. And then what's the minimum that you would have there? So again, for 1 through 4, you need a policy and procedure. You can have one policy procedure like this example that covers all of them. You don't need to have separate ones. And then also you need reports. So for 2 and 3, you need a report. You'll see that it's 7 days, and I'll give you an example of those. And then for the last one, you actually need, I mentioned this earlier, you need screenshots. So you're going to need to show examples out of your EMR, and you're going to need at least one example during business hours and after business hours that you documented in the patient's chart. So here's a sample report of telephone response times. Again, is this something that, do you have in your EMR the ability, do you have an audit, do you have some type of call log that you can just get out? Do you have custom reports already made? Does your system have CAN reports? Do you need to contract with someone to build you some reports to pull this data out? Most EMR systems you get the right person in your organization or you outsource to the right company, you can probably get that data in a report if you need it. Or do you manually go in and maybe you have a call center staff and someone's logging this, or maybe you ask someone to log the report. Remember, the report has to be 7 days. So you could certainly have a 7-day log if you needed. And then what's the response time, right? That's what you were asking for. Do you meet the response time? Same thing with secure messages. You know, in this example, it's fine. It's a month's worth of data. You really only need 7 days, but and oftentimes this is stuff that can be gotten out of your portal pretty easily, depending on your portal. But what's your response time? If you said I was going to do it within 24 hours, how many messages and what's it look like? And then here's a sample. I think I mentioned this on the intro, but because some of you weren't on that, I just want to highlight again when you get to the screenshots, please make sure you don't send PHI. So make sure you block them out. They don't want to see that. They're going to look to see that you have everything that you said you needed, but this would be an example. Okay, electronic access. So I've often been asked, if I don't have an EMR, can I become a patient-centered medical home? The answer actually is yes, because this is just a subset of points. But if you look at this, I'm going to talk about online access, ability to view patients, download chart. All of you that are on the phone that are in this line of work, you should start thinking MU right now. These should all look familiar to you. These should all look like the original stage 2 menu items, clinical summaries, more than one business day, secure messaging. Patients have two-way communication that I can ask you something through the portal, you can send it back, not that I'm just sending to, and that I can request appointments, prescriptions, and refills electronically. So before I get too far down the pike, because there was a modified ruling, NCQA, I want to say it was November of last year, came out with their recommendations after the modified ruling. And you'll see their response. In some cases, even though CMS, LNC had made the decision that they changed the metrics, in some areas you'll see NCQA did not take that stance because they really felt that to give the best primary care to the patients and deliver the best quality and low cost, that you really need to do this. So, you know, the first one, the fact that they have online, as long as you have, as long as you can show that you have access, that's sufficient. The view, download, transmit, at least for this year, if you look at the standard, as long as you have at least one patient, that would work. Clinical summaries, many clients still give them out, even though the MU was given away. You don't necessarily have to meet the threshold, but you at least have to have the capability. Same thing goes with secure messaging. So I'll just say, just because MU changed, please look at NCQA's responses for each one. We're just talking about this factor for now, but there's other factors that have a lot of MU in it because they aligned with MU, and you'll often see where we didn't change, NCQA didn't change much from the original standards. Scoring is pretty straightforward, not a lot of points, 2 points. That's why I say you can actually get, right, there's total of 100 points. You can not have an EMR and still potentially get this. Well, way more challenging, and most people do have one, but put that out there. No critical factors, no must-pass on this. And pretty straightforward, right? A lot of this is going to be this might be one of your easiest ones. You need reports. Many of you probably have these reports that are part of your EMR that are going to come out, and you're going to get that. You're going to need 3 months of recent data. So don't go back a year. If you're submitting now, go back in the last 3 months or no longer than 6, numerator, denominator. And the key point is this is the site or practice level. You do not do this at the individual level. So depending on your EMR, most have the ability to do it at the provider and at the practice or site level. Please be clear that if you only have it at your provider, you need to roll that up at the site or practice. They don't need to see it at the provider level. And so that's pretty clear for the first 4 that I mentioned, and you know those are the clinical summaries, the view, download, transmit, and the patient portal. For the areas of 5 and 6, so the two-way communication to patients, and the ability to request appointments. This is you showing you can do a screenshot, and I'll give you an example. You need to be able to show, and you can just take it off of your website, and I'll give you an example of that. So here's a report of the first three. Again, I'm at the practice or site level. So if you have multiple sites, each site you have to give that report as an example here. And then what you can do for the other one where you've got to give the screenshot, you know, you can see here that patient has the ability to view lab results, radiology, they can access and request, they can send messages. This meets both of them. You know, I didn't highlight in this example. Some people will snag it and say, here's this factor 5, this is factor 6, but this covers all the areas of what I can do, and I have the URL that's available to them. So that's the areas that are going to be quickly looked at when you put your survey tool in. All right. We're going to focus on PCMH2. So stretch, wiggle, and then we'll open up the questions. So team-based care, my guess is this is the most challenging for some because when I get to element D, the practice team, the first 2 or 3, in fact, element B, medical homes, probably your easiest. You can write that down right now. It's your easiest to fulfill. It's really a policy and procedure probably for most of you, but practice team is probably going to be the most challenging. This is a total of 12 points. Remember, PCMH 1, standard 1, patient access was 10, this is 12, and I'll go through each one of these. And I won't have as many now that you've seen some of those screenshots, but I'll cover each one of these so that you get the gist. So continuity is pretty straightforward for those of you who were on 2011. This looks familiar. Basically, you have the ability, I as a new patient in your organization, I have the ability to select a PCP and that it's listed in my EMR or in my patient record who is my PCP. Also, how often can I get an appointment with my PCP? Maybe I need to get in, and whether it's routine follow-up. Am I going with the person who's my primary care provider that I picked, not that you told me was available, but that I chose because I researched? So that's 1 and 2. I researched, I picked that one, they were available. And then number 2, how often do I see someone else because I really have an issue and I can't see my own? What's your process for new patients today? Do you give them a welcome packet? Do they get walked around the clinic? Here's how you call us, here's what you do. You're going to see this is a lot of policies and procedures. And then how much do you collaborate and develop that care plan with a patient when you have pediatrics going to an adult care? So if I'm a well pediatric, you're going to be seeing, you know, I only see pediatrics, you know, you're 21 is my cutoff. You're now going to see this is what you should be getting. Or maybe I have a diabetic pediatric patient. So what's that handoff? What's that process going to look like when you're switching to an internal medicine or family doc? Scoring for this is pretty straightforward. This is one of the odd ones where if 3 factors doesn't mean 75%, it's just the way it cut out, you get there's no 75% you can get on this. So you either get 25, 50, well, 0 is 25, 50, or 100%. Now that you're sort of seeing the flow of things, date, practice, name, so you need to define in your policy and procedure how do you let someone pick their personal physician. What's the new patient orient process? Every new patient will get a welcome packet. In that welcome packet, they'll understand how often they can come in, what type of the appointments, who do they call, what's the off hours. The other is defining that process for pediatrics. So I have some of these examples for us. Let's talk about the reports. So for 2A2, you're going to need a report for 5 days, and that's going to show how many times did I try to get an appointment with my provider and what's the percentage that I had it with my actual provider. For number 1, which remember for number 1, we're looking at does your EMR have the ability to document that patient's choice of personal EMR? It's basically a screenshot out of your EMR that says, here's where our PCP field is, and this is the process that it gets put in there. And then number 4, which is transitioning from PEDS to, I think I do have an example of this for a diabetic, and there's guidelines out there for transitioning that you could certainly use and download as well, but giving those materials to your pediatric patients, and you're basically going to take a screenshot and give them an example of that when you submit your survey tool. So here's an example of the report for your percentage for your personal physician. So you can see I've blocked out who those actual providers are because they were real providers, but basically here's all the patients that were seen by their personal physician, and here's the percentage. So in theory, you need to look at the one that's down here with, you know, why is this one so low? Is their schedule not booked, or are they just seeing overflow? Do they not have a big patient panel, and maybe that's why? Maybe they're a mid-level that's seeing everyone else's patients, but they don't have that big of a panel. Understanding and looking at this and guiding to, you know, do you need to get more physicians on board? Do you need to rearrange schedules? And then here's an example of a checklist. Again, it's sort of saying, here's what's going to happen, prepping your pediatric patients to basically, can you take care of yourself? You know, ironically, I had a niece that went to something the other day, and she was like, oh, well, what's my card? How do I fill out this form? And she's 21. So it's a prime example of today, and I don't know, I like to say at 21, I'd seen, well, I was in healthcare, so obviously it made sense to me, but it's shocking that, you know, if you've always attended your appointments with your parents, that sometimes these people don't know how to navigate the healthcare system. So this is about how do we transition this. This just happens to be about diabetes, but it could also be about well check. Okay, I mentioned that this one was probably one of the easiest ones, and I think it is. Here's just a list of all the things about patient-centered medical home. So basically that we're going to get your, how do you contact us? I talked about that in your new patient packet, during office hours, off office hours, getting the complete medical history. How do you transfer your records? What's the care team? We're going to talk about that in a moment. Who's a part of your care? How do we do that? We're going to give you evidence-based care. We're going to give you self-management tools. What's the scope of services? If you don't have behavioral health in your organization, how do you get access to it? All of these, and basically a policy and procedures, which you're going to have in place here, is showing what the definition of PCMH is, essentially, why I said it's probably the easiest one. Basically, you're saying you're going to take all patients regardless of their source of payment. How do you get coverage and instruction on that? And then who's the point of care, contact of the practice, and how do you records if you're coming from someplace else? I'd like to say this is an easy one to do because in theory, it's a policy and procedure for you. And I'll give you an example of it. The scoring for this one is 2.5 points out of all those factors. I think this is the easiest 2.5 points you can get. And here's what you need to meet that. You basically need a policy and procedure written that covers, and you can define what the medical home is and just put it in your policy and procedure and then incorporate that in your brochure, your welcome letter. Maybe that's what you give. If you say PCMH or patient-centered medical home, most patients don't know what that is. This is your obligation to the patient to sort of say, we're a patient-centered medical home, this is what it is, and this is how we're going to provide you care. This is why we stand out to everyone else. Certainly once you get recognized, you do want to promote this on your website. You do want this on your providers' pages as well. This is a distinguishing factor in healthcare today that shows you're on the cutting edge of delivering high-quality care. So what's an example? It's pretty straightforward, right? It's basically you having this policy and procedure. This could be a screenshot of a brochure that you would hand out to someone. It's defining and telling patients what a PCMH center looks like. All right, let's move on to 2C, because I do want to make sure we have some time for Q&A, and I want to spend some time on practice team that's coming up. So culturally and linguistically appropriate services. Most of you who have been around for a while with MU, you know you get language, race, and ethnicity, even though some of that changed with modified pooling. In this case, we're incorporating some of that, right? We're looking at the diversity of the population. So that does include things that I just mentioned, such as race and ethnicity, but it also includes things like education level, gender. All of that would count as things that you look at. Maybe I'm looking at a subset of my population, so, you know, maybe I think people of a certain education level or a certain gender orientation, all of that will count, or race, ethnicity may deserve something different in my practice, or I need to cater to them. Maybe I've got a certain ethnicity and a certain culture that I need to be mindful of and respectful of. Language is pretty clear, right? Is it English? Is it Spanish? Is it Japanese? Do I have the materials I need? It's you seeing, if you assess that you know what your population is, so that you can then provide the services. That's where 3 and 4 comes out, right? That I'm meeting those needs, that I've got a certain type of patient population, and that I'm prepared to care for them. Scoring for this one's pretty straightforward too, 2.5. This is simple. Again, no must pass, no critical factors in this one. And then what do you need to give? 1 and 2 are probably easy because of meaningful use. Many of you probably can just push a button and automatically have them pop out. But I'm assessing race, ethnicity, and 1 other diversity aspect. Again, you could do education level, you could do gender, socioeconomic status, you know, whatever is appropriate based on your patient population. And then assessment of language. Policies and procedures, you need to have one that says, maybe after you've done this, you say, if we need and we have someone that comes in that doesn't speak any language, how would you address that? Do you have a policy and procedure? If your population is 100% something, then you could say, if someone was to come in, we would contact this service. How do you deal with that if you don't have that? And then, depending on what your percentage of your languages is, do you have materials that are in other languages? Does your EMR provide those materials, or have you gone and pre-printed them or paid someone to do them? And you're going to need an example of that. So it's a combination of reports, policies and procedures, and examples. So here's an example of report. Again, for many of you, your EMR, if you're under MU, you probably can pull out some of this pretty easily. So you see that the report that you actually have to give, and then I've put race, ethnicity, and in this case I put education. This would be sufficient, covers 6 months of everything you need here. All right, so the best for last, another must-pass and critical factor. And this is where I think a lot of your transformation is going to take time. This is about having care teams and working a little bit different than maybe 1, 2, 3 clinical staff to a provider. Defining who's in the care team. So if I'm provider X, do I have RNs? Do I have medical staff, the front desk? Do I have certain people? Defining the roles for each one, both the front desk to the clinical and non-clinical. What's that structure? And how am I going to care for that? The critical factor is that I have a daily, what most people will hear, it's the critical factor in the must-pass, that I have team huddles, that before the beginning of my day, or in some cases I've seen team huddles be split in the morning and then in the afternoon before the beginning of each session. Maybe you print out the daily schedule, maybe you've got a formal agenda. I'll give you an example of an agenda in a minute, that I'm going through and say, you know what, here's the blood work that needs to be done. Oh, we really have to talk about this patient, that you're going through and looking at all the people coming in and what are the key areas that you need to touch into. You're not waiting till the patient's in there and trying to figure out, but you've sort of mapped your day. And this, I'm going to highlight, does not have to be the provider, and I'll talk about it a little bit more in a minute, and I'll look at this. And in fact, in most cases, it's often probably more appropriate for your clinical staff or your MAs to do some of this stuff with the provider or the mid-level listening in and sort of guiding, yep, I agree with that, oh, can you make sure that the work happens? And this is that you use those standing orders and services that you need to, right? That before the patient comes in, streamline their care, but that you've looked at the big picture. That you actually have patients and that they're assigned members of the care team, so that I, as a patient, I know who my players are. I know the full team, not just my one MA, not my just one nurse, but I know all the people that could be interacting with me. The training and assigning, that I'm going to train my staff. Do they know how to, am I giving annual, semi-annual training on how to get patients to change behavior? Do they get training on self-management techniques of weight, diet? You pick based on your patient population what you need to train them on, but this is the policy and procedure, the things that we're looking for. What's the patient population I'm really looking for? Am I really looking for maybe the uninsured? Am I looking for the people who are in a different language? Am I looking, and do they know how to manage that patient population? Do I have like the sickest of the sick, and how do I monitor and manage them? And training people to how to define the right patient population. Holding scheduled team meetings, 8 is different than 3. 3 is a care team huddle about your patients coming in that day. 8 is about you're having office staff meetings and saying what works well, what doesn't work well, something that most people do occasionally. And again, NCQA is not saying how often you have to do it, it's just that you're doing it and you're defining how often in advance based on your organization. And that you're involving not only your staff, but also your patients in quality improvement. Remember, I mentioned earlier in the last one, you're going to see this common theme that you're constantly looking how to improve the way you deliver healthcare. Although Standard 6 is going to be all about quality improvement initiatives, you can see how this is, are we really looking at how we deliver the care team? Do we have them and we know how well we're executing and delivering care in the concept of the care team? And that we're getting that information both from our staff and our patients. Scoring on this one is 4. Again, please note, this is a must-pass. So again, you've got to get the 50% to get any points. If you look at that and all of those factors I just covered, you've at least got to get 5 factors out of that list, and the care team huddle has to be a part of it. The care team meetings have to be a part of it. So usually this is usually different. This is usually something that most organizations don't do formally. And there's some really great videos on NCQA's website of a sample care team huddle. You can actually see YouTubes of it. And if you reach out to me, I'm sure I can dig some out of what one looks like running it. But this really is transforming your practice on sort of having people work at the top of their licensure, really being more proactive versus reactive when the patient comes in. Okay, so the first one, pretty straightforward, 1 and 2, jobs, roles, and responsibilities. And I do have an example of this that I'm going to show in a little bit, where here's the roles and responsibilities, here's the staffing structure, maybe an org of my care team, who I call first. Care team meeting, who runs it, how often are they run, what's the communication like, and then you're going to have to give examples. So not only the policies and procedures, you're going to have to give examples. And they can be, you could have just, I've seen a daily schedule printed out and people, here's why they're coming in, HTN, DM check, and maybe they've scribbled on top of the minutes, oh, can you make sure we get a lipid panel because they're overdue, that type of thing. And then if you don't have standing orders, I hope most of you do, because oftentimes I'll see where, oh, if I come in and I've got a sore throat, automatically get me a rapid strep. You have the approval to do that. That's sort of a standing order. So if you have standing orders, an example of one. And I won't show all of those, but I'll show some. So for factors 5 through 7, everything about training. Do I define care coordination, the initial training? So I'm training my staff, right? This is the care team staff. That's what 5 is. Then I'm training them on care coordination. Excuse me, this is how we're doing referrals. This is who you contact. This is the process. And how often do I do that? Just don't do it once. Staff turns over, but also things change. Also, giving core training to your team on how to communicate with patients. How many of you actually have training to your staff about, we just get into our jobs and we never go back and look. Something I recently heard was having empathy training to really think. It's easy to get caught up, but understand that patients are coming in with real stuff and feeling empathy for them. That could be an example. And then what type of tools and evidence are you giving for self-management support? So do I give out flyers, pamphlets, what's that training? And this is about you training your clinical staff of here's the tools, here's the information you need so that they can deliver that to the patient. And then I talked about the population health management. In addition to the policies and procedures, which all of that could be in one if you so choose to do, you're also going to need to show a training schedule or some examples from such trainings and a description of what the training. So you can say annually or semi-annually, we provide this training, this is what the description of the training is. That's what's being looked for. And then for 8 and 10, this is the staff meetings as well as the QI stuff. You need to have a policy and procedure to say we're going to have staff meetings every third Monday. They'll be at this time. This is who attends, who runs them, defining the roles on policies and procedure. And you'll see for 2D, you also need to have a sample agenda and the minutes from such meetings. And again, one thing is to have the policies and procedures to say this is what we do, the other is to actually show that you do it. And here's an example, right? Pretty straightforward of everything that I've sort of covered. I'm putting who the roles are. It's just a suggestion, not necessarily what you have to do. And then an agenda basically says how long the daily huddles are going to be. This is an example of a policy procedure that would pass. All right. Well, people, we're almost near the end. So I said I'd do a crosswalk. And I know not all of you are currently recognized probably on this call. Some of you are just seeking recognition and just learning. So for those, for 2 slides, you can sort of blank out. What I put on this slide, these are the items that are different. The link that's at the top is you can get a crosswalk from NCQA on the website that maps it out. They always do a crosswalk from one standard guideline to the next. Here's the ones that are different. So, you know, for those of you that are very familiar with 2011, it was providing same-day appointments. In general, they added routine in now. All of the availability appointments, monitors, and no-shows, these are all the things that are new in 2014. So for those of you in 2011 that have been doing fine, you've been monitoring, maintaining, these would be the areas of focus for you to see if you have in place. This is your low-hanging fruit when you're up for renewal, if you're up for renewal. And recommendations are that you go a year out from when you're due to be recognized, that you start planning and begin the process. Don't wait until 3 months before and then miss out on renewal. If you miss the date, there's no grace period here. And then standard 2, you can see there's a lot more. Now, for those of you that were very familiar with 2011, as I walk through them, you'll see where some just got shuffled around or got put into different elements, but all of these on this screen and that previous screen, these are all the new things, things that would not have been in place in 2011. So in some cases, you'll see maybe it's a new policy and procedure. Maybe you need to have a new report. So these are all the standards that you're going to have to see in the new 2014 recognition process for those that are up for renewal. So what's my recommendation to all of you on the phone? One, continue learning. Based on the introduction we did, and I know some of you are returning, a lot of you are looking to do this over the course of the next 6 to 12 months. If you're in 2011 going to 2014, my recommendation to you is take the crosswalk that I just showed you or take those bullets. Make sure that you're meeting all the things that you thought you were in 2011. If you don't audit at least twice a year, I think you're in jeopardy of being really shocked, right? We all know we can introduce something, but adoption then sort of dribbles off if we don't maintain it, right? So I look first of, are you meeting where you need to meet for 2011? And then look at the gap and say, okay, here's all the new things. Do I have a policy? Do I have a report? What do I need? You can certainly use this deck as an example. Try to figure out, is it just that I've got to do policies and procedures? Because those might be painful to get approved and processed or right, but somewhat can be easy. Or do I need an organizational change? Do I not have care teams and I've got to go explain how we're going to do something totally different? That can take significant time. And do I need reports? Am I going to need to hire someone to come in to manually build those reports? Do I need to hire someone to do some technology on those reports? Do I need to go to a different department in my organization to get my custom report writer available to me? And again, if you have a long list, it's so much easier to start crossing off the list. Many of us like to cross off the list. So I say figure out what you can do easily. You know, I said the medical home, the one that was just about writing a policy procedure, just at least do that. It feels good to write that off. Here's an example of something we've built internally, and it basically outlines a quick way. I mean, again, if you open the standards and procedures, basically what I've done here is said, okay, I have a total of 4.5 points. I either have the policy and procedure where you see this X, and you'll see another screen in a minute where that links to, and I'm going to need 5 days report. So I'm either going to say yes or no, I have it, and then I'll see where, and then this tells me, so anything that's in red, I know, okay, I don't have a report, so I either got to get it manually or I've got to have someone build it for me. And then when I do, I can get that point. This tells you where are you in that bucket of level 1, 2, and 3. For policies and procedures, you can certainly go through the standards and guidelines. I've sort of pierced that out, much like I did in the slide. What's the minimum you need? If you have an existing policy and procedure, then look to see if it has the key things that are going to be looked upon when you go to, after you submit the survey tool. What's your NCQA reviewer going to look for? And you're either going to say yes or no. Again, date and practice name. Probably the one thing that's very easy, if you have something, go and put them on. If you're 2011 and you haven't done your revision dates, do that. Take a day, go through them and stamp them, sign them out, and get approval from your organization. All right, so here's all the references that are available to you. They're all NCQA, so I've put 2 things in here. The standards and guidelines, if you don't have them, you get them at the NCQA store. They're free. I would recommend that you get the appendix. Things are constantly not changing as much as I see changing sometimes in MU and other areas, but they do change. There's feedback given, and so, you know, like I pointed out, consecutive days, it used to be 5 days for one of those, and now it's 5 consecutive business days. And then the last one's a crosswalk. So I will end there. I know this has been extremely lengthy, but I did leave about 10 minutes left for Q&A. So I'll take a look at those, and I leave you with sailing in Santa Monica Bay, and there's my cute poochie for you to see. So when I'm not thinking about this, that's usually what I'm doing. So lastly, I did say I would keep this up at the end. There's 2 things I'd like to do now. I'm going to, 1, open a poll. So for those of you on the phone, I'd appreciate feedback from the poll. So a couple things I'm going to ask. Did you learn something new today? And did you find this webinar useful to you seeking PCMH recognition? I didn't give you an open answered section, but what I would ask is at the end when you close out your WebEx, because this is the first, well, this is the second of a 4-part series. So we covered standard 1 and 2 today. The next month we're going to cover 3 and 4. It's going to be a similar format. So for those that signed up, if you didn't like what you heard today and you want something different, look, I can adjust and adapt just like the Plan, Do, Check Act we mentioned again. So feel free to share, and I do appreciate your feedback. You can copy these down. Again, you can get this WebEx recorded either from our website. You'll see the slide down on the wiki. You can also ask for it in that section. We'll give it out. All of you have access to it. And with that, Sin, I'm good for you to open the line. And I will just check to see what we might have in QA while the poll's running.
All right, I'll unmute everybody right now. The lines are open.
And I don't personally see any Q&A questions unless I'm missing something, Sin. So I'll just ask if folks have questions. I know there's tons of information. I'm happy to take them. Crickets. I've either scared all of you or you already knew all this stuff. One of the 2 is my guess. All right. If you have a question answer and, well, question, I presume you wouldn't have the answer, you're asking me, and you didn't type in the box, but you think about it as you close out the session, feel free to also put that in. We will answer any Q&A that you put in, whether you put it in after this is done in the last piece, that will also be on our wiki for you to read if someone asks something. But at this point, if no one has any questions, and I don't see any in the Q&A, I appreciate if you entered the poll, and we'll close the session. And I do appreciate everyone's time. I hope to see all of you back on, let's see, that next session is coming up soon. It's just a couple of weeks. So for those who don't know, on May 13th, we'll be covering deep dive on Standard 3 and Standard 4. And thank you for their time today.